Hello, and welcome back to Simontific. We have another great episode for you today on sickle cell disease, specifically looking at a new treatment method that is changing the way that patients and medical professionals think about the disease and the best way to treat it. We hope you enjoy. Let's first hear from Dr. Adetola Kassim, professor of medicine in hematology and oncology at Vanderbilt University, who also serves as director of the Adult Sickle Cell Disease Program and clinical director of the Adult Stem Cell Transplant Program.
What bothers me the most is the most affected population being able to have access to these innovative therapies. I think that's really the main challenge.
We'll hear more later on from Dr. Kassim about this issue of access to medical treatments. But first, let's hear Dr. Kassim explain what sickle cell disease really is.
Sickle cell disease is what you call one of those monogenetic diseases. That is a disease that starts with just a single mutation in the gene that produces blood cells. However, the consequences of those amino acid change in the chromosome is that you produce red cells that are deformable. And those deformable cells cause downstream effect, whereby when they lack oxygen, they kind of change shape. The effect of that on the lining of the blood vessels and the blood cell itself is what you call vasculopathy or inflammation. And that's kind of widespread throughout the body. Now, that deformity in shape also causes other cells within the blood to aggregate and stick together. And so the small capillaries in the body get occluded. And that occlusion is what causes the myriad of pain syndromes that these patients get, in addition to organ damage.
As Dr. Kassim just explained, sickle cell disease is when red blood cells become rigid and take on a sickle shape. Those misshapen cells stick together, blocking blood flow, which means those cells can no longer carry oxygen the same way that healthy red cells do. Now let's have Dr. Deva Sharma, a hematologist and transfusion medicine physician at Vanderbilt University, chime in to explain how transfusion therapy, which takes healthy donor red blood cells and adds them to a patient's bloodstream to dilute sickled cells and restore normal oxygen flow, has been a life-saving treatment method going back to the 1960s.
Transfusions can decrease the risk of fatal complications like stroke and acute chest syndrome. And in those situations, we do exchange transfusions where we use a machine that looks like a dialysis machine to exchange out the patient's sickle red blood cells and replace with healthy red blood cells. And we know that this is immediately life-saving for acute complications. But we also know that chronic transfusions can be really beneficial for these patients. For pregnant women with sickle cell disease, for example, none of the FDA-approved therapies are safe for pregnancy. So chronic transfusions are really the only disease-modifying therapy we can offer a patient during this really important time in her life. And for curative therapies, transfusions are a really integral component. The high-dose chemotherapy we give with gene therapy or with stem cell transplant, it really ablates the bone marrow to a point where the patients are transfusion dependent for at least a few weeks. So we really can't safely offer curative therapies to these patients without blood transfusions.
Let's now go back to Dr. Kassim to hear a breakdown of the history of treatment options for patients with sickle cell disease.
We've always known for decades that if your stem cells are diseased or they don't work, by getting rid of them and putting new ones is curative. We always knew that, especially in the setting of malignant diseases. But we also know, apart from cancer, there are other inherited diseases that have more of a benign or slower course, like thalassemia, like sickle cell, like inborn errors of metabolism in children. These are kind of more benign diseases with variable costs, not like malignant diseases where if you don't do something about it, most of those patients die.
As Dr. Kassim explained, we've known for decades that stem cell transplants could potentially cure sickle cell disease, but until very recently, the technology hasn't been reliable or widely accessible. Today, there are two main curative approaches: gene therapy and stem cell transplant. Gene therapy works by taking a patient's own stem cells into a lab and using CRISPR to edit out the part of the DNA that produces sickled cells. Once those edited cells are infused back into the patient's bone marrow, they can begin producing healthy red blood cells. Stem cell transplant, on the other hand, relies on a donor's healthy stem cells. Those donor cells are infused into the patient to replace the sickle cell producing system with one that can generate normal blood cells. Now let's hear Dr. Kassim explain how he decides when transplant may be the best option for a patient.
Just like any other disease, there's a variety of manifestation, or what you call a spectrum in manifestation of a disease. There are those who are pretty severe, and those that are, frankly, mild. We know that those with severe disease, especially if they develop subsequent organ damage, can lead to early death. Likewise, we also know that those who have what you call more recurrent acute manifestations, which is typically pain episodes, also can lead to untimely death because of severe complications. So in this subset of patients, either with those with repeated acute complications or those who are manifesting chronic organ dysfunction, since you know the outcome is early death, those will be those who I will consider for transplant.
Not all patients are eligible for a stem cell transplant, but recent advances are allowing far more people to qualify than ever before.
One of the greatest advancements now is that we can, instead of a full donor match, we can now use a family match who is only a 50% match. We now have a better way of controlling the immune turbulence when you use less than a perfect match, because the main complication you get from that is graft versus host disease. And part of the new preclinical studies that came out of Hopkins showed that you can really control this with a drug called cyclophosphamide. And so the application of that has been extremely helpful in making this a safe procedure for less than a perfect match.
Dr. Kassim explains how transplant technology has evolved dramatically over the past few decades.
The transplants we do now is quite different from the transplants we did 2 decades ago. Because then, like I told you previously, we didn't have much tools to manage the complications going through transplants, like the extreme nausea and vomiting, like the graft versus host disease, some of the infectious complications. We didn't have tools to tackle them. But in 2025, we now have tools that can actually do this. So people still look at transplant from that previous point of view. For example, in terms of the fertility complication, we now know that you can do what is called fertility preservation, where you can preserve somebody's fertility and they can decide down the road if they want to have kids or not. So it's different. In fact, some of the regimen we use for transplant now are less toxic than what you would do if you did gene therapy. There's still a lot of myth about it, that people need to understand that it's actually curative for transplant, and the fact that now almost, guarantees almost a 90% cure for eligible patients, that we can now use beyond just a sibling for the transplant. Parents can be donors, first-degree relatives can be donors, second-degree relatives can be donors, uncles, nieces, nephews, aunts. So I wish people will understand that more, that there's a curative option out there that is within reach.
And as these curative options improve, the role of transfusions is starting to change as well.
Chronic transfusions are life-saving for patients with sickle cell disease, but they can also be burdensome for some patients. Literally every month they have to come to a healthcare facility for a day and interrupt school and work to get transfusions that are necessary to prevent stroke and organ complications. I think that for more patients, transfusions may become no longer a destination therapy, but a bridge to curative therapies. So I think that's exciting. This has been historically, again, an underrepresented patient population that has been difficult to capture and get into the clinic due to healthcare disparities and various other factors. But gene therapy has really excited patients. Patients come in the door saying, I want you to cure my sickle cell disease. What can you do for me? And then, of course, it takes a lot to get to gene therapy. There's a cost. They need a caregiver for at least 100 days. But gene therapy and curative therapies like transplant get patients in the door, and they're excited to come here and excited to engage with their healthcare team about managing their sickle cell disease. And I think healthcare professionals who are previously indifferent to sickle cell disease are suddenly very excited about the disease because the bedside and the bench side have sort of merged very quickly. Like, who would have thought that, 10 years ago that we would have CRISPR-Cas technology or lentiviral technology to do autologous gene editing or gene addition in hematopoietic stem cells. So I think that people who were previously disinterested in the disease are suddenly very engaged and interested. So even though not every patient with sickle cell disease is offered curative therapies, I think it's benefited the field from multiple perspectives. So I think that the advances in science definitely need to be met and accompanied by efforts to bridge the gap between these healthcare disparities that affect this predominantly Black American patient population.
When asked about the problem of accessibility, Dr. Kassim responded,
That's the greatest challenge. Because when you look at this very sophisticated therapies, they're expensive. And in the United States itself, realizing that more African Americans or ethnic minorities are affected with this disease. And if you look at them in terms of insurance spectrum, they're probably likely underinsured or uninsured. So it poses itself a challenge getting them the transplant. Gene therapy is even way more expensive than a transplant. So that itself is another huge challenge, especially if the government will have to bear the costs.
And these barriers don't just exist in the system. They affect patients every day. Here's Karina Wilkerson, a nurse practitioner who works closely with these families.
The financial barriers is one because it is expensive, right? And a lot of times, depending on the insurance, a lot of these patients may have insurance, but they may not have all the access that they need. So they may be uninsured. And so some things are not covered. So like housing and food, transportation, those can be challenges for patients and families, whether they are in-state or out-of-state. And, of course, the out-of-state transportation is going to be a little bit more costly because those individuals may have to fly or have a long travel to get to in-state. So the financial barriers, the psychosocial component is a very an area of interest.
And these challenges extend far beyond the United States.
In Africa, where a lot of people live less than $1 a day, this even poses a significant challenge to getting this therapy to the epicenter of the disease. So being able to find philanthropy, other means of being able to adapt this approach locally to places like Africa, I think is the next frontier.
This global issue will require global effort. Let's hear from Dr. Kassim about how the widespread distribution of these treatments can become possible.
The momentum has already started. It's to look for what you call easily adaptable ways of doing the same therapy without, busting the bank. Supply chain issues need to be improved to make drugs accessible, and to try and do transplants that are less risky, more straightforward, that already has been shown to succeed. I think we'll begin to improve accessibility both here as well as in Africa.
These treatments have improved outcomes for many patients, but they also carry risks and side effects.
I think one thing to note is that the curative therapies are fascinating and exciting, but they can compromise fertility for men and women because all curative therapies, whether it's gene therapy or transplant, do require high-dose chemotherapy, and that is a serious consideration for patients. They want curative therapies, but they don't want to jeopardize, their ability to have a family and have a happy life after they are cured. So I think, fortunately, I have a lot of colleagues across the country who are seriously thinking about this and focusing a lot of research efforts on the optimal timing and strategy to offer fertility preservation to these patients.
I have patients tell me all the time that, it's different because now I don't have sickle cell disease, or I'm anxious because my headache is just a headache. It's not something sickle cell related. I might hurt my arm, but I don't have to come into the ER for this. So just the transitioning from having a chronic disease and no longer having it, it's difficult, and it's an identity. I don't want to say crisis, but they're having some identity challenges at this point to figure out who they are without sickle cell disease. And so that's a challenge. And then just going through this process all together. And some patients are not even familiar with other sickle cell patients, so they're trying to find support groups that are out there so they can connect, so they can actually have someone that they can talk to that they feel like can relate.
And for one patient, those side effects meant compromising something she cared about most, her fertility.
Tiana Wolford is a woman in Baltimore, my hometown, living with sickle cell disease, and she tells her great story. She underwent a bone marrow transplant for sickle cell disease more than a decade ago. Her doctor told her, you should undergo this transplant because you might die if you don't do it. And she said, I always wanted to have 6 children. What should I do about that? And she looked into options for fertility preservation, but because she didn't have a cancer diagnosis, it wasn't covered for her. And so she told her doctor, I've always dreamed of having 6 kids, but he said, well, you better not die of your sickle cell disease and do this transplant. So she did, but unfortunately she rejected her allograft, and the transplant failed, and now she has sickle cell disease and her fertility has been compromised. But she did start an organization called SC Red, which is a nonprofit that does research and advocacy for people living with sickle cell disease. And a bunch of us are writing a patient-oriented grant with her to improve reproductive health education for people with sickle cell disease. But I think her story is an example of how she had a negative event in her life, but she turned it into an amazing nonprofit for which she's a CEO, and she's thriving and sort of giving talks and fundraising across the country. So I think the patient stories are really what keep us motivated and keep us doing this work.
Dr. Sharma reflects on how sickle cell disease has shifted to an adult population since treatment options have kept patients alive past childhood.
For women with sickle cell disease, pregnancy is one of the most exciting moments in their life. They're growing a family. Historically, there's been a stigma or a bias towards this patient population. A lot of healthcare professionals have told them you shouldn't have children, you're going to pass on sickle cell disease, or your pregnancy is at such high risk, you shouldn't risk your life to have a kid with sickle cell disease. But I think we're entering an era of new therapies and new advances in transfusion medicine and curative therapies where people are really asking important questions about how we can improve the management of pregnancy, this vulnerable time, but also very exciting time. And I think it's important to consider, too, that in the 80s and early 90s, before we had hydroxyurea and penicillin prophylaxis and other treatments for sickle cell disease, most patients died in childhood. But now, in the era of curative therapies, patients are living longer and longer, and family planning and reproductive health are of increasing concern as this has shifted to an adult population and a survivorship population. So I think it's great that more people are thinking about this and focusing on this.
Just like we've seen a tremendous progress in the last decade, I have a feeling another decade from now we'll see even better evolution in, better infectious disease complications, better graft-versus-host disease management, and also better positive control of any late complications of transplant.
That wraps up this episode of Simontific. Thanks for tuning in. We hope you enjoyed it.